Okay, so hi, my name is Ayya Keshet, and I'm joining you from Israel, and thank you for having me here. I'm part of the SEGA lab at the Weizmann Institute, and I'm going to talk about working with the EHRs for research, and I'm going to give you the researcher's perspective. And okay, so let's start. So first, I'll talk a bit about our lab. So the SEGA lab is a really multidisciplinary lab with researchers from many different backgrounds. We have several diverse data sources, and I myself have a background with computational biology, so both biology and computer science, but we also have people with background of medicine. We have doctors coming to do their PhD studies. We have biologists, physics. So it's really a diverse lab. And we have a lot of data sources that we work with. So could be omics, proteomics, metabolite, and electronic health records, which is going to be the main topic of my talk today. And let's first talk about this big data era that we're in the midst of. So many technological advances in the past decade has transformed many aspects of our lives. So it's not just medicine or research. We can see it in machinery. We can see it in cars, in automatic vehicles. So in the data domain, it allowed for the vast increase of also the types of data and also the scale of data that we could keep. So it started from, for example, in the genome data, the whole sequence, whole genome sequencing, and now we have large data sources of genomic information about many, many people. It's also imaging data and electronic medical information. And all this data also started, resulted in various new algorithms and methods which allow for the exploration and the utilization of this data to ask different scientific questions in the medical field, and not just to answer questions which are about the biology of the disease or its progression, but also questions which try to improve the medical care. So, like I said, data types vary from genomic data to image data. And so, in general, we're going to talk about health data. And health data, as opposed to, for example, textual data or imaging data, has some unique features which are separates it from big data in other domains. So, and it can include administrative health data, biomarkers, biometric data, imaging. It originates from clinical registries, so biobanks, like we saw before, patients, self-reported data. Also, there's a new entire field of wearable devices. So, for example, the Apple Watch, which measures your heart rate, or applications which track your physical activity or diet. So we have a lot of sources where data can be generated and streamed. And we can look at each data source. So once we have some source of data or some information gathered together from a specific source, we can characterize it by several axes. So we can look at a large data set, and we can represent it by different axes. So each axis represents a quantifiable property of the data. We can look at the data and try to quantify it. Some axes could be very simple, like the number of participants, so how many users or subjects do I have in that data source? It's pretty easy to quantify, or the longitudinal follow-up, so how much time have I followed up each individual. And some axes can be a bit more complex, and they can't be quantified by just a single number. So, for example, the depth of phenotyping, so we can think about some information we have from a wearable device. So we might have some identifier and measurements of heart rate. So it's not very deep. And we can think about maybe a resource where each individual has its whole genomic information sequenced, so it has a much more deep phenotype of the individual. So these axes, some are more complicated to quantify and measure, like the depth. Some are more simple, but it's obvious that in the research field, we do have limited resources. So we won't be able to reach some perfect or the most wanted data set that has everything on everyone with maximum follow-up time. Of course, each axis costs more money if we want more participants or if we want a deeper cohort. So there's always a trade-off between the axes, and as a result, we can locate each data source on some plane or in dimensions in terms of its axis, and that affects what questions can we ask from that data set. So if we have a really shallow data set, for example, like I mentioned earlier, data from Apple Watch of heart rate, we don't have a lot of medical, we can ask a lot of questions, but we're limited by the number of questions or research questions we can ask on that data set. So we can see here, for example, comparing just two axes, the number of participants and the phenotyping depth, and we can see that the data sources, they vary. So we can see randomized control trials, for example. They are pretty small in the number of participants, and they're also relatively shallow. They're not so deep in the phenotyping. So we can see here, for example, deep cohorts. So, for example, cohorts that really do a whole maybe genome sequencing or metabolomics or proteomics profiling on their individuals. And we can see here electronic health records. So electronic health records, we see we have a lot of participants, but depth is relatively low. So what are exactly electronic health records? So an electronic health record is just a digital record which contains the patient's medical history. So it could be different from one country to another, and I saw the first lecture where they talked about integrating and integration and how can we standardize it, but each source affects the information which is contained. So it can contain demographic information about the individual, lab test results, diagnosis, prescriptions, the physician notes. In some cases, it could be also linked to image data. And most of these data sources which generate the electronic health records are purposed to serve administrative tasks. So, for example, tracking the patient's care in the clinic or the hospital, or managing their bills and their payments. What do they need to pay for their medical care? And so we need to remember that most of these data sources weren't collected directly in the purpose of serving scientific research. And we'll talk about it in a few slides, but this causes some challenges in working with them as a research data source, because it wasn't in mind when constructing the data and when collecting it. So let's look at an example. For example, we have here two patients, patient 1 and patient 2. They both have medical records, and we see here the dates between December and July, and we can see each point is a measurement taken, and we can see on the left which kind of measurement. So it can be weight or height, blood pressure, whether they visited a community clinic or the hospital, lab results, or pharmaceuticals, so whether they got or bought a prescription. And we can see that patient 1 is really different from patient 2. Patient 1 has data points along the whole timeline. It has many data points. And patient 2 only starts in the middle of the. We don't have a lot of information about him prior to that point where he starts. So, for example, if we would want to use these two patients just as an example for some research question, we will probably have have a bias and a problem with the data, because we have an entire section here where we have information about one patient, but we don't have anything about the other patient. This also happens in large scale. When we look at 1 million patients, then we need to remember that the one patient might seek for medical care and the others didn't. So this causes for a lot of variation in the data. So I want to talk specifically about the data source that we have in the lab of electronic health records. But before that, I want to explain a bit about the healthcare system in Israel so it would be more clear. So the healthcare system in Israel is based on the National Health Insurance Law. And this law requires each citizen in Israel to be a member in one of the health maintenance organizations. The patient receives all its medical care, their doctors, lab tests, everything through that, and it's compulsory. So every person has to choose one of their nonprofit, and they are required to give service to any Israeli citizen who wants. So you have a free choice of one of the four. And there's direct oversight of the HMO by the country, so it's regulated. And the Clalit is one of the 4 HMOs, and it's actually the largest one. So it has over 4.5 million different patients, which is more than 50% of Israel population. So it's really diverse and really represents the entire population. It has over 1,500 clinics and 14 hospitals, which account for 30% of Israel's beds. And they started relatively early working with electronic medical records. So they started logging and saving their information electronically, starting from 2002. And we in the lab have a collaboration with them, and we have all the data from 2002 until 2020. So it updates on a nearly half year, 2 times a year it's updated. So we already also have information from 2020. So it's really a long time of follow-up for people, for some people who members of that HMO the entire time. And one more important point is that the turnover rate is really, really low. So it's really rare for someone to switch HMO in their lifetime. So most of the time they join when they're born, their parents register them to a certain HMO, and in almost continue with for the rest of your life. And the information that we have in these electronic health records, so it contains many of the things that I mentioned earlier. So we have diagnosis. It could be from community clinics or from the hospital. So it appears in the diagnosis codes, ICD-9 codes, if you know them. We have information about drugs, whether they were prescribed or whether they were bought. We have lab test results, so blood and urine. We have anthropometrics and vital signs, so weight, height, and blood pressure, which is measured when you see a doctor or when you come to the hospital. And we have some information about demographics. We have information about the ethnicity of the person and the family tree, which is really interesting and important in some of the projects, and we'll see that moving forward. So we do have a connection. Each person, we know how to connect him to their family, how we have an identifier for their mother and their father, and thus we can build an entire family tree, because if we have information about the mother and the father, we can find its brothers, we can find the grandmother and the grandparent, and we can build an entire tree which connects families together. Okay, so this is the data that we work with in our lab. And as I mentioned, because electronic health records, ours included, weren't collected with the thought of research in mind, there are some challenges when you do work with them as a data source for research. So here are some of the challenges. The data quality. So as we saw, for example, in the 2 patients example, where one had many information and many data points, and the other didn't have a lot of data, so we have missing values. We don't have everything we want on every patient, and we have to somehow deal with that. The accuracy of the measures, so it's not always accurate to 100%. At the end, the people who register this information at the end are physicians. You come to the doctor, maybe he types in the summary of your meeting, and he types in the codes of the diagnosis or the prescriptions you received, and he might have errors. I mean, we all are human, we all make mistakes, and he might enter some information that isn't correct, isn't what he intended. So we also have a problem with accuracy. We have a bias in the process of the data collection, as we saw in the patient 1, patient 2 example. So most of the measures are taken when patients come and seek for medical attention. So it's not that we have what we would want, which is measurements taken randomly at some points in time. When the patient feels bad or thinks something's wrong or just wants to see a doctor, you go to the doctor and get. It also changes from person to person, maybe from culture to culture, or from family to family, or from their possibility or the care that they are given, or maybe the distance they live from the clinic. Maybe people live closer to the clinic, visit the doctor more often. So we do have a bias which affects how many information we have on each patient and when is it measured. Another thing is that to extract meaningful information, we do need to work with domain experts, which is mostly working with physicians, which understand from the domain of the question of the specific research question. Because as you saw, we have a lot of data points, for example, weight, blood pressure, height. But for example, if I want to study diabetes, then I need some medical expert to tell me this is how a medical record looks like when a person has diabetes. It has this diagnosis code, or he received this prescription. I mean, it's not as simple as you have a column which says diabetes and whether the doctor checked it or not. So we need to extract meaningful information from the data using meaningful expertise that people who know the system have and work with it. And we have the data itself, its high dimensionality, its heterogeneity. These are main features that make it difficult to work with electronic health records, as opposed to maybe some structured data sources, like, for example, imaging. So despite all these challenges, we do, and there are some very interesting research questions which are answered using EHRs. And many data scientists refer to their work as gaining insight, or, like we said, extract meaning. But this might seem like a very vague and broad definition of the work, which is actually could be described in a specific way. And one way to describe it was defined by Miguel Hernán at an article he wrote at 2019. This enables us to think more systematically about the types of data and analytics that are required. So let's dive in. So what Hernán defined is that there are only 3 classes of learning tasks that we can do with the EHRs. And each task requires different types of data and different domain knowledge, and also different analytics. So different statistical methods that can be used to answer that question. So the 3 classes are description, which is when we want to obtain some quantitative summary of certain features of the data you've all heard of. So we want to use some input features and map them to some output feature of interest. And counterfactual prediction, which is a certain type of predictions, but we want to predict certain features using input from the data, but in a scenario where the world would have been different. And I'll explain later on what does that mean. So the first task, like we said, description. So it could be elementary calculations of some some quantities in the data. So for example, the mean or the proportions of sick individuals in the data. Could be some clever visualization of the data, which I can then learn some insights from. Could be unsupervised learning algorithms, so for example, clustering analysis. And here I give an example of one work which was done in our lab, which studied childhood obesity. So the question was to look at all the children born in Israel that we have information on in our data and try to understand at what age or how many children develop obesity in their childhood years between their birth and the age of 5. So we can see here examples of some descriptive plots. So for example, here we see a plot which has 3 descriptive elements. On the left, we see the distribution of children in terms of obesity when they're in their routine checkup at 2 years of age. So we can see here some quantitative summaries of the data. So for example, we can learn that 73, almost 74% of the children are normally weighted at that age. And on the right, we see the same thing, but at the age of 5 or 6. And the last descriptive thing is the flow between them. So how many children which were considered normal weight at the age of 2 also were considered as to have a normal weight at the age of 5. So this is one example of some descriptive work. We took this question of childhood obesity, we did some calculations of summary statistics, or we displayed it in a nice plot, and we did a description. So the next task that I mentioned is prediction. So here we have some outcome of interest, which we know from our data, and we want to learn a mapping from some input variables to that outcome of interest. And here, for example, we can use analytics like learning algorithms, which can vary from logistic regression, which is considered the most simple one, to neural networks, which could be the most complicated one. And here we have another example of a work done in our lab, which predicted the gestational diabetes. So this is a condition which sometimes occurs in pregnant women, which develop diabetes during their pregnancy. And today in Israel, every pregnant woman, during the pregnancy has to take an exam during the 24 to 26 weeks of her pregnancy. But this costs a lot of money, and most of the women, they don't develop gestational diabetes. So here, what this work that was done in the lab, they tried to do, they tried to map using information prior to the pregnancy, or even just at the beginning of the pregnancy, learn what is the probability of that specific woman to develop gestational diabetes. So when we can see the evaluation of the model here. And as I'm sure you know, in a prediction problem, we know what we want to learn. So for example, here they collected all the women, and they extracted from the electronic health records the information whether they had gestational diabetes or not. And that was the target that they learned to predict. As opposed to, and this is the third class that we talked about, is the counterfactual prediction. So counterfactual prediction comes to answer what-if questions. So for example, let's say that I want to observe some, I want to learn some effect of a drug. So let's say I have a drug A and B for diabetes, and I want to ask which drug is better, which one I should use, which one the doctor should prescribe when some woman or man comes and is diagnosed with diabetes. So what is the problem? As opposed to the prior slide where we had the outcome for each pregnant woman, we knew whether she had or didn't have gestational diabetes diagnosis. Here, we only observe partial information because the information we have in the electronic health record contains the information about the patient and what treatment he received from its doctor. So each patient, the doctor, he got either treatment A or treatment B, but I don't know what would have happened if he received the other treatment. So I have a sort of missing information problem. I can't compare my population with the treatment A or B because I only see what the patient actually received from the doctor. And we'll see, so the gold standard, so I'm sure you all know of this term. So if there's for example, there's a new drug in the market and we want to test it, so we want to compare it to an existing drug, then we take a group of people, a group of people that match our description. So for example, if it's a drug for diabetes, then we take people who have diabetes, and we randomly divide them to two groups, where one group will receive treatment A and one group will receive treatment B. And since we randomly selected who will get each medicine, then the only difference between them is which medicine they received. So at the end of the trial, if we'll see a difference in their diabetes status, whether it's improved or didn't, then we'll know that the effect was only due to the drug, because everything else was selected randomly, because each person was random. That's not the case with observational data, and we'll see in a few slides why. And here I'm going to dive in a little deeper to this class of tasks and describe a project that we've been working on in the lab for the past almost a year and a half, from our electronic health records, which is estimating the causal effect of cesarean section delivery, which is our treatment, on the long-term pediatric health. So this project is done in collaboration with the two other PhDs in our lab, Guy Rossman and Dr. Esmadar Shilo, and also with people with the Rabin Medical Center, which is one of the Clalit hospitals here in Israel. So one of the hospitals that are part of Clalit, the HMO that we have the electronic health records from. So when we talk about what-if questions, meaning we want to ask what if, what's the actual quantity we want to evaluate? So that's the average treatment effect. So we have a question about some treatment, in this case, C-section, cesarean delivery, and we want to know how does that treatment affect some health outcome. We want to know whether it's bad or good. We want to give that information to the doctors so they can make a more informed decision when they give that treatment. So what we would want in a perfect world, you can see it on the left. Let's say this rectangle is our entire population. What we would want to estimate is take the entire population, give it the treatment, and then see what's the outcome, whether their health is damaged or not, according to the outcome that we defined. And then let's take again the entire population, but this time we won't treat them, and we see how this affects the outcome of interest. And then we could compare this and whether the outcome with the treatment or without the treatment was better. But of course we can't do that, because once we treat our entire population, then they're treated and they're not the same population anymore, whether they took a drug or whether if we're talking about the birth of children, the child can only be born once in one way. So of course we can't do that. And what we have in real life is we have our population of interest, and we have some division between people who received the treatment and people who didn't receive the treatment. So we have the population of children born in Israel that we have in our data, and some were born through a C-section, and some were born vaginally in a regular birth. But how can we exactly compare between the two? Can we? Maybe we can just compare them. So let's see whether we can or not. And just before that, I'll give an outline about the treatment and why we chose that treatment and this question. So cesarean section, C-section, is a life-saving procedure for both the mother and the infant when it is medically indicated. So in some cases, this is a procedure that saves the life of the mother and the child when she can't give birth. But in terms of health, long-term health, and despite those risks, the rates of cesarean sections are rising around the world with an annual rate of 4%. And the problem is that the risks which this procedure bears are not completely known, because conducting a randomized control trial, like we mentioned, is challenging and maybe can be seen as unethical, because we can't really take women and randomly decide whether they give birth through C-section or vaginally, right? So don't have an actual measure of how much does this affect, or maybe it really affects in such a small amount that we shouldn't take it into account. But it's important that we try to know so that doctors can make an informed decision when deciding about this. So this is from our data in the lab. So this is at the top you see the total birth rates, number of births in each year from 2002 until 2018. In blue we see vaginal birth, normal birth, and in orange we see the C-section. And we see that the rate at the bottom is relatively stable, even with a little decline. So in Israel, the rates are not rising, but worldwide they are rising. And some countries, for example, in Brazil, more than 50%, more than half of the births which are performed in a hospital are done through a C-section. Probably more than is medically needed. Okay, so we talked about the average treatment effect, and we saw that we can't take our entire population and treat it once and then not treat it. And let's see why is that a problem? I mean, why can't we just take all the data we have in the EHRs, compare all the children that were born through vaginal delivery or C-section, and just see whether these children get more sick in the future or these ones. So randomized control trial, as we said at the beginning, we randomly select the people. So we have here a treatment group. So let's imagine that we could have had an RCT, and we chose these women that they will give birth in a C-section. And these women will give birth vaginally. And each woman who was colored in red, diagnosed with diabetes, and the green ones are not diagnosed. So if we take a large enough sample of people and we divide them randomly, then we believe that the difference between the treatment and the control in the number of women which have diabetes will be equal, because we randomly selected women. So we will get some women sick in vaginal, and if the sample is large enough, then it will be equal. But what happens in observational data, which is what we want to use to estimate the effect of our treatment? Then what happens here is we can see that in the treatment group, we have less women who have. In the control group, we have more women who have diabetes. What does it mean? It means it was one factor that the doctors considered when they took the decision about whether this woman will give birth vaginally or through a C-section. So diabetes is a factor that affects the treatment assignment. But if the outcome of interest, for example, will suffer from obesity in his childhood, then we know medically that diabetes of the mother affects obesity of the children born. So diabetes doesn't only affect the treatment, it also affects the outcome. What does that mean? It means that if we have in our control group more women who have diabetes, then we also have the probability of their children having the outcome of obesity is also higher, but that doesn't stem from the treatment itself, right? Just from the process. And this is what is called a confounder. Okay? A confounder is a factor that affects both the treatment assignment, but also the outcome. And it causes an effect which makes it seem like there's a difference between the two groups of treatment and control, but that effect doesn't stem from the assignment of treatment alone. It stems from the confounder itself. So that's why we can't just use observational data. We can't just compare the two groups of children born vaginally and through cesarean section. We need to somehow control for these confounders. So as I mentioned in the section of the 3 tasks, I said that it's important to define exactly on which task we're working on, because once we know on which task we're working on, then we'll know what data we need for the problem and what statistical methods were developed and already exist, and we can utilize them to solve the problem. So once we know we are in a counterfactual prediction problem, we want to estimate the causal effect, we can follow one method, which is called the target trial, which is a study design which deals with these issues of confounders and bias in the data. So in this design, we envision a randomized control trial. Okay, we imagine what would the criteria of a randomized control trial be if we could perform one, and then we try to emulate it as best as we can with our data from the electronic health records. And I'll skip this. This just shows a real example from research that was done that showed that observational data, which came into some conclusion, was wrong because they didn't follow the target trial. And once they followed the target trial method, they saw that there was no effect of the treatment on the outcome. And I'll skip that and I'll just show you to get a feeling of how we define it. This is the definition of the target trial emulation from our project. So on the left, most left column, we see the protocol component. So when you construct a randomized trial, you define the eligibility criteria. Who are the people who can be included in our trial? What is the treatment strategy? So in our case, vaginal or C-section birth. How is the treatment assigned to people? What are the outcomes of the interest? What do we want to learn the effect of the treatment on? How much time do we follow up with our patients? And what is actually the statistical analysis and the statistical quantities that we want to achieve? And right columns, here in the middle, we see the specifications of our perfect imaginary randomized control trial. What if we could actually run this trial in the hospitals in Israel and randomly select women? And on the right, for each point here, we can see how we best emulate it with our EHRs information. So for example, if we want birth between the 1st of January 2007 and December 30, 2017, then we can identify this birth in our EHRs because we have date of birth in our data. And we can choose these women. Or for example, if we don't want to include premature birth, children who are born before time, then we have information in our EHR system from the hospital, which is a premature flag, which basically states whether the child was born before the time, and we can exclude by that all the records that were not going to be included in the original trial. So this is the definition, and then we try to, as closely as we can, emulate the trial with our data. Okay, so I defined the target trial and I defined which people I take, and I ended up with some, I don't know, 200,000 births of children in Israel, that some were born vaginally and some were born with a C-section. And like we saw in the example of the diabetes and the obesity, I know that I can't directly compare the both groups because of the confounders. So how do I deal with confounders? What do I do to get rid of their effect and only remain with the effect of the treatment? So let's look at two possible ways to deal with that. So the first is called standardization, and it's really obvious and clear when you think about it. So let's assume that X is some feature vector which contains all of my confounders. So in the example before that we saw, we had only one confounder, which was a diagnosis of diabetes. Then X would be whether a woman has diabetes or doesn't. So in the subpopulation of subjects that have exactly the same, share the same feature vector. So if we look at the diabetes example, in the subpopulation of women who are diagnosed with diabetes or the subpopulation of women who are undiagnosed with diabetes, then in that subpopulation, we don't have a connection between the confounders X and the treatment assignment, right? Because once I look at all the women who have diabetes, then I know they have diabetes, but inside of them, there is no effect anymore of diabetes on the treatment effect, because I know that they all have it. So I can look at that population and look at the two groups of women who were treated and untreated, meaning gave birth through C-section or through vaginal delivery. And I can know that the effect between them of whether the child has obesity in the future stems only from the treatment, right? Because the effect of diabetes is no longer there. They all have diabetes. And in the group of all the women who don't have diabetes, again, the fact that they all don't have diabetes doesn't affect the outcome, only the difference between the treatment. So in my example, X was only one feature, but of course we have many, many features. So we'll have many, many subgroups. And in each subgroup, we can estimate the effect of the treatment. And if we want to achieve the average treatment effect, the statistical quantity that we wanted to achieve, that we talked about, for the entire population, then we just have to do an average over X and average it according to the weights of each group. So of course, not each group will be on the same side, but I can just take a weighted average, and then I'll have the estimate for the average treatment effect for the entire population after looking at each subgroup individually. So this is one way to deal with the confounders and get the effect of only the treatment itself. Another method uses something which is called a propensity model. So a propensity model learns a quality which is called a quantity, which is called the propensity score, which is just the probability of an individual to be treated. So, for example, in our case, it's giving all the features on a pregnant woman. What is the probability that she will give birth through a cesarean section? Okay, she will have a cesarean section. And once we learn this score, we can learn it from the data, right? We can take, we would want to take all the information that the doctor is taking into account when they assign the treatment. And we would want to model the doctor's decision as well as we can from the data. Once we have that, we will see why the propensity score is a balancing score. We can use that score to balance our population and deal with the confounders. So before we talk about how we do the balance, I want to talk about the doctor's decision. So as I mentioned in the challenges of working with the electronic health records, to get meaningful insights, we need to work closely with domain experts. So, for example, in this project, we worked closely both with pediatricians and both with obstetricians, so gynecologists and people who really learn the gynecology, to get the most that we can about the problem, which is already known. There is a lot of prior domain knowledge that doctors already know, specifically, and most importantly, doctors which at the end prescribe or decide on the treatment. So, for example, doctors which work in the hospital in Israel, which we collaborated with, actually make the decision on a daily basis whether a woman will give birth through vaginal or cesarean section. And working with them, for example, I'll show here an example of how we get this propensity model, this model that learns what is the probability to treat, that a woman will be treated or give birth through a C-section, from raw data. So at the beginning, we have raw data, just like we saw at the first slide with the patient, one of the first slides with the patient 1 and patient 2. We have information about the woman. We have her weight and diagnosis, whether she was pregnant before, or maybe family history of problems, and we want to first construct phenotypes. So this information, which is raw information, still doesn't tell us anything about the health of that woman. So we want to learn whether she has diabetes, whether she was diagnosed with hypertension, whether her children that we want to follow up have the outcome of interest. Were they really obese as children or not? So these are created using phenotyping algorithms, and these algorithms are all defined by physicians, by doctors who work with the system, because they know, first they know the system, they know all the diagnosis and prescription codes, and they know the process in which a patient comes to the clinic and he gets sent to some lab tests or he gets sent to buy some information, whether this means that he is actually diagnosed or not. So, for example, there are some drugs that can be prescribed to several different diagnoses, and we won't know just by that prescription that the subject received whether he is sick or not. So we might need to combine, and it happens a lot, we need to combine information from many sources. So, for example, if we want to define a phenotype of diabetes, we'll need to look at whether they were diagnosed by a certain code and also treated with some medicine and also had some lab results with a certain value. So in this process, we work closely with the doctors to define how do we construct its algorithms, how do we construct these phenotypes. And to create the propensity model, we don't want to take into account everything that we have, because we want to get a model which is as close as possible to the doctor. So we need to use knowledge about how the doctor assigns the treatment and look at all the variables that the doctor states that he takes into account. So, for example, I want to know about a cesarean section, which is our treatment. What affects the doctor's decision in deciding whether he will give this treatment or not? And once I have all this information, I can build my model. And this is, for example, the evaluation of our model, which learned the probability of a patient being treated or not treated. And we can see here, for example, in the blue, the AUC curve, which is with the area under the AUC of 0.89, which is pretty good. So this means that our model learned pretty good what doctors take into account when he gives the treatment, and what's the probability of a woman to be treated and give birth to a C-section. And now we will see how we can use this model, or the scores that this model obtains, the probabilities, to the confounders. the propensity score, the probability of being treated, to weigh different samples with different weight. Okay, so I won't get into all the math here, and I'll just explain that there are, maybe you know, inverse propensity weighing and overlap weights. The propensity score to weigh our population. And I'll just say that once we weigh, we give this weight to each sample. Then we have sort of a new population, right? It's not the original population where each individual was an individual on its own, because maybe some individuals are more interesting for the problem than others, and they'll get a bigger weight, and then we'll use the information from higher weighted individuals to learn more about the problem. So this is like a sort of pseudo population, it's called. And we can see here in the plots below, which is really what's important, in orange, in emergent orange in ones, we see the absolute standard mean difference, which is a measure of the difference of the feature between the population of children who were born vaginally and through C-section, in all sorts of features that were interesting. And in blue circles, we see the difference after we created this weighted population. And we see that the difference gets really, really small, also in this method of IPW, but even more in this method which we used. It's almost zero in all of them, which what it actually means, it means that we achieved new populations of treated and untreated, children who were born vaginally and through C-section, which are actually identical in all of the features, in all of the confounders. And what is the only difference between them? The treatment. So now we can use these new populations to assess the effect of the treatment on the outcomes. Because once again, through this manipulation, we receive the population, which is almost like a randomized control trial. That is the only thing that affects the outcome. Okay, so up until now, we talked about the statistical quantity that we wanted to assess was the average treatment effect. But the average treatment effect is estimated only at a single time point. So for example, if we look at the example of obesity, then I can ask what is the effect of being born with a cesarean delivery on the child being obese at age 5 or at age 10. But you see that this or makes me lose a lot of information. Why? Because if I have the question about the age of 10, I want to know the average treatment effect on the age of 10. Then I need information from all the children who were born a long time ago, because I need to follow up until the age of 10, right? Otherwise, I can't do that data. So I need to lose a lot of subjects if I want to look only at a single time point. Also, I might be dealing with missing data, which was one of the problems we talked about when working with electronic health records. So I might have children that don't have any information at the age of 10, whether they are obese or not, and I wouldn't be able to use them. So another more interesting estimate that we chose to work with is survival analysis. So maybe some of you know it, but survival analysis estimates at each point in time during my follow-up. So for example, if I want to look at children, I will have the probability at each age until the age of 10. So at 1 year and 2 years and 3 years, so on until 10 years, I will have what is the probability of the child being obese at that age. This way I gain more information because I can use my entire data set. I can also use children who were born 2 years ago, and I also have 2 years of follow-up for them, because each child contributes information for the follow-up that he has about the probability of being obese at that age. so I won't lose data. I have more information. And also, learning this survival analysis might also help me learn about the onset mechanism, about the development of the outcome itself. For example, if I will get a graph which shows that most of the children develop obesity at a certain age, maybe I will try to understand what is the biology behind that and why children start to get obese at the age of, for example, 5. I'm just giving you an example. So other than just learning a single point, it tells me a more complete story, allows me to ask broader questions about the biology of the disease and the mechanism. So how do we go from estimating this single point of average treatment effect at the age of 10 to looking at the entire timeline? So we use a method, I'll just explain it briefly. It's called pooled logistic regression, which takes the format of our data, which is, for example, here we see 3 individuals, 1, 2, and 3. And we have a different follow-up for each one of them. So, for example, one was, we only have 1 year, maybe he was born 1 year ago, and the other 2 were born 2 years ago. And whether they were treated or not, and whether they are obese, for example, whether they have the outcome or not. So we will turn this matrix of data that we have in the raw EHRs to a pooled data frame, which means that for each patient, we duplicate him according to the time of follow-up that he has. Okay, so for example, the first patient, we only have a single time point for him. Okay, we only followed him for 1 year. After 1 year, we asked whether he was obese or not. So we only have 1 row. But for example, for the second and third patients, we have 2 years of information. So we can say, okay, the second patient at the time point of year 1, we know he still wasn't sick, but at the second time point, he was already sick. Okay, so that way we enlarge our information, and each individual contributes to all of the times where he was included in the follow-up. And individuals, subjects that have more data will contribute more because we have more to learn from them. We have more follow-up time for them, so we can learn from them more about the onset of the disease and whether it occurred or not. Okay, so I'll go over some of the results of our actual project. So as you remember, I explained about the target trial and how we define which women will be or children will be included or excluded, and Emulation, which we finally ended up with. And we can see here we have almost 240,000 children who were born between the years of interest. And we can see that 84% of them were born in vaginal, so this means no treatment, right? And almost 16% were treated and were born through. And let's look at some of these examples. So, for example, in terms of the height of the mother, we don't see really a difference between the two groups. So maybe height isn't really a confounder, right? It doesn't really maybe affect the treatment. The treatment assignment, like we talked about. But do you remember when I gave the example about diabetes? So we can see here that women who were diagnosed with diabetes, there are 1.2% of women diagnosed with diabetes, children who were born vaginally, but it is in the C-section group. So this is just one example. We can see it also occurring in hypertension. We have less than 1% of women who have hypertension in vaginal birth, but more than 2% in C-section birth. So this is just an example from the real data, from our real data in the lab, why we can't just compare the two groups of vaginal and cesarean delivery, just one by the other, without using the methods that we mentioned about dealing with confounders. because these two diagnoses also affect the child's health in the future. So if we'll see a difference between these two groups, we won't be able to say for sure that this difference is only due to the treatment. And that is, at the end, what we want to achieve, okay? And the next slide. So what I'm showing here is an example, just an example of survival curves. So as you remember, we wanted to estimate the probability of being sick at each time point. So here on the x-axis, we see the month of follow-up. So we see we have up to 120 months. So it's the age of 10. Here the child is aged 10. We see two graphs. The orange one is always the C-section, so the treatment group. And the blue one is the vaginal one, so the control group. And on the left, we see the survival probability. What does that mean? It means what is the probability that you won't be sick with, for example, here we see asthma. So at the beginning, everyone is not sick, of course, when they're just born. For example, after 20 months, we see that 96% of C-section will not be diagnosed, but a higher percent of children who are born vaginally will not be diagnosed. So this means that children who are born through C-section will more probably develop asthma. Okay, so here, for example, we do see a difference. For example, on the right, for atopy, we see a much smaller difference. And for example, here we see two outcomes. ADHD, for example, attention deficient disorder, and diabetes, for example, which we talked about. And here we don't see much of a difference. So here, and this is after we used the method of standardization. Remember, this one is when we divide our population to small groups, where in each group, all the features are the same, except the treatment, and then do a weighted mean for the entire population to get the overall effect. Okay, so any difference we see here in these graphs, we strongly believe that it only comes from the treatment because we controlled for all the rest of the confounders. Okay, so I showed you really nice plots, and I'm telling you there's a difference between children who are born vaginally and the C-section, or maybe there is no difference, but I don't know the ground truth. So when we talked about the three classes of tasks, the second task was prediction, and we said an important point was we actually know the outcome. We know whether a woman was diagnosed or not, or sick or not, and that is what we learn. We have the ground truth, we have what to compare. But here, we don't know the ground truth because, as we said, we can't conduct a randomized control trial. So we don't know the actual true effect. So how can we evaluate and know whether these plots I showed you actually mean something, actually give us a true estimate? So there are some ways that we can evaluate when we are doing counterfactual predictions, evaluate our estimations, and gain confidence. So sensitivity analysis is when we try to replicate our results under many different conditions. So for example, one example of sensitivity analysis is to use different statistical methods to evaluate our survival curves. So the plots I showed you, I told you I used a standardization method to estimate the effect. I can also use weighing. Remember, we talked about the propensity model and the weighing methods. And when I compare them, of course, there are differences because there are always differences when evaluating and estimate through different statistical methods, but the overall should be the same. So whether I see an effect or I don't see an effect, it should be the same regardless of the statistical method if I really controlled for all the confounders. Another way to evaluate our results is using negative controls. So there are using domain knowledge of physicians, we do know that there are some outcomes. For example, in our case, we chose arm fractures okay, a fractured arm. We know that this has nothing to do with whether a child was born vaginally or through C-section. So we could use that outcome, evaluate the effect, and see if we don't get an effect, we see that there is no effect. We gain confidence in our process and in our statistical methods. Another very powerful way is to try to replicate the effect using another validation set. So here it's extra challenging because when we talked about the structure of EHRs, we said it's not always identical, it doesn't always contain the same information. So when we want to run the entire process that we built in our lab, for example, on another data source, we'll probably need to have some adjustments. But if we will achieve the same evaluation, then we will gain a lot of this in our results. And at the end, ultimately, when possible, we will always run the randomized control trial. And of course, like we mentioned, it's not always possible. It's not always the case. It's not like a new drug that enters the market. And in some cases, there are some cases where we won't be able to ever do a randomized control trial. So I'll just give an example of some sensitivity analysis that we did in our project. So first, we, like I mentioned, used different statistical methods. Second, we analyzed our estimations on different subpopulations. So for example, instead of taking all the population of children born, we only took, for example, siblings. We took, remember I told you that in our information, we had children born in the same family, siblings, when one was born through a vaginal delivery and one through C-section, and compare between the children whether they got sick in, for example, asthma or obesity as they grew older. Why is this good? Because this controls for a lot of environmental factors that were not available in the data, that we don't have. These two children were raised in the same family, got the same medical care, so that is a much closer population with less confounders, less things that are different and might get in the way of our estimation of the treatment effect. And negative control, I mentioned, which is arm fractures. And I'll just show you two examples and we'll finish. So here we see the graph for asthma development, and we see here 3 different methods. So on the left, it's standardization, like we talked about, looking at small subgroups which have all the same features and then doing a weighted mean for the entire population. And the two right are the 2 ways we talked about of weighing the population and getting a pseudo population with the propensity model. And although we see there is difference between the methods, I mean, for example, on the most right, the confidence interval is much larger, but the effect remains. We do see that there's a difference between children who are born vaginally and through C-section. And this causes us to gain confidence in our results. And here I'm showing you the same thing, asthma. These are all estimated using standardization, but on different populations. So the most left is the entire population of C-section. And for example, the right one, the population I told you about of siblings. So why are the confidence intervals here so large? Because as you can imagine, we don't have a lot of siblings. So we really narrowed down our cohort, our population, when we only looked at siblings, and siblings where one was born vaginally and the other through cesarean section. It's not that common. So we do have a really large confidence interval because of the small population and small amount of data, but we see that the effect still remains, which also creates confidence in our results. So I want to thank you for listening and giving me the opportunity to show my work, and also the lab members you see here, which some of them worked with me on the project. And I think we have time for questions if you have some questions.
Thank you for your presentation. So can you tell me how much time did it took from the beginning of the, like from the research question till the results?
Yeah, so this, I mean, it's a little hard to quantify exactly because in the middle we had the COVID period when we worked on different things really related to COVID. But I think I would say around from the research question and the first meeting with physicians to try to understand what is the problem, whether it's interesting, and do we have enough information to, until today, a year, maybe a year and 2-3 months, something like that. I think it depends on how many people work on the project, because here we were, me and Chagay, who is another PhD at the lab, we were both working on the computational side, which takes a lot of the amount of work. So as I mentioned, building the algorithms which create the outcomes and the features, and building the entire pipeline of the statistical methods can take a lot of work in terms of coding and building it. So we were 2 people working on it, but we also had other projects in parallel. Yeah.
And I think, is it like you saw at the beginning, you showed us that there are many phases where actual physicians are involved, and like, did you receive some feedback from them where you had to really change something what you do?
Yes, so at each step throughout the way, we were in constant communication with the physicians that we work with. And for example, if we wanted to define some feature like diabetes or hypertension, they gave the initial algorithm and definition. We went and coded, worked on coding it from the data, and then we did some descriptive analysis that shows what's the result, what's the output of the algorithm. So for example, how many from the cohort are diagnosed with diabetes, what's their ages, and then we gave this description to the doctors to see if it really matches their knowledge and what is known in the literature about each feature and each outcome. If there were things that were really different from the known medical knowledge, then they needed to investigate and see what went wrong or where was the definition of the algorithm needed correction.
Okay, thank you. Sounds complicated. So I see someone has raised a hand, so you can ask a question.
Yeah. Hello, Ayya, Keshet. I'm Adi. I'm from University of Dundee and a PhD student in epidemiology and biostatistics. A very nice presentation indeed on electronic health record. And I also learned today a new trial experimental methodology, which is quite new in epidemiology and evolving. My question to you is about when you talk of putting or coming very near true towards using observational data, and you say that the only way we can go to the true is randomized control trial. But at the moment, with the emerging field of observational data, that's quite getting limited day by day. Why not we go to the new method, instead of going to the new method of trial epidemiology, we go to the new original method of case control design? Because if you do a case control design and you satisfy all the assumptions of case control design, it can replicate the results of the randomized control trial. I would just like to have a brief comment from your end that why have you tried to use that design?
No, so actually I'm not very familiar with that. So if you'd want to maybe with case control design, so if you'd maybe want to give just a brief definition of what is that.
So case control, where you will have a certain people with cases and certain people will control. Of course, you can do a follow-up with them, but there will be a specific time point of follow-up with everybody. And then you define after 5 years or 10 years that who were my cases. Suppose in your experiment, it would be outcome of obesity with gestational diabetes mothers. And you follow the gestational diabetes mother from the day they are diagnosed with gestational diabetes. And yeah, and then you start the follow-up period with them, and then you end the follow-up period with the day their first child becomes obese. So then now your cases definition will be the people who become obese, and the control will be who do not become obese. So in a way, you will have a case control design, and you can, that very well satisfies, if done it right. Of course, there are a lot of assumptions in case control, but if you do it right, you can very well replicate the results of a randomized control trial. I mean, it's just a suggestion.
Yeah, so you are.
Sorry, continue.
So I actually I don't know in depth that method, but it's really an interesting remark, and maybe we'll need to think about it. But in terms of what you said, I understand from the design that you have to have information about a certain time point, right? So if I want to, and that's where we lose a lot of data. So when I talked about the transition from average treatment effect to survival, the main advantage is I can use the entire data that I have, regardless of how much follow-up time do I have. So, and I guess in the case control study design, I have to define a certain time point, and then I also have to have that information on whether the child developed the outcome or not to include them in the study. And we will probably lose a lot of information and reduce our cohort size to sizes really, really small, in which it will be really difficult to estimate the actual effect from sizes that small. Yeah. So I guess that's really an advantage of the survival analysis.
Yeah, survival is good, and I think with your current research question, it is quite true what you highlighted, that you will end up losing a lot of samples, if at all not taking a lot of them, or else you will pick up people who just develop cases, and your proportion of cases and controls will be different. Because the unsaid rule in case control design is for one case you need 2 controls. So that balance should always be there. The proportion of 2:1, and yeah. But it was quite interesting. Thank you very much.
Thank you. Thank you.
Yeah, and also I have another question about this target trial method. It was developed for this, for that data that is collected before the beginning of research. I understood correctly?
So the target trial method was developed. It's really an epidemiological method, which is really old, but now with the renewal of it by Miguel Hernan, he has a lot of articles about it. It's meant to address and work with observational data. So it's perspective. I mean, we already have the data. It was collected previously. We have the observations, and we define based on that, on the information that we have, what is the trial that we think we can emulate. So of course it doesn't work for any research question, because we need to think about, and this is why the first step is important, of defining your target trial and then trying to emulate it, because you might end up with you might think of a question which is really interesting, but with the data you have in mind, you can't emulate the trial. So you have to make sure that the data that was collected can also be used to emulate all the parts of the trial definitions.
Oh, thank you. This is very interesting in terms of sustainable research for biobank cohorts.
Yeah.
Okay, if someone else has a question, maybe. Okay, it looks that not. And so then we are going in a lunch break and we'll be back at 2. Yes? Thank you, Ayya. It was very interesting.
Thank you so much.